hysterectomy cases are having vaginal wall, which is not true. It's always there. Loss of vaginal wall support results in pelvic organ prolapse, and approximately 40%, 45% of cystocele and 55% of rectocele is due to vaginal wall prolapse. Something these are, I will escape all this. The important point here is that when we evaluate it, anyway, the top of posterior vaginal wall is the highest part of vagina. Vaginal wall is equivalent to vaginal level 1 section. Look at this graphic. So this shaded area, dark shaded area, so that is level 1 section. This is posterior. This is the top of vagina. This is posterior fornix. A scale is placed in the posterior fornix. This is the cervix entering through the anterior fornix. This is anterior wall. This is the entire length of anterior wall. This is entire length from here to here is the posterior wall. These are hymen keratosis. So posterior wall is equivalent to vaginal level 1 section, that is from top of vagina to 1 inch below it or 2.5 centimeter below this point. Now on an average cervical length is 2.5 to 3 centimeter in non-parasitic. And in pre-hysterectomy cases, anterior fornix is shorter and at a lower level than the posterior fornix. It means that posterior fornix is behind cervix and this leads to vaginal apex. Cervix enters through the anterior fornix. During hysterectomy, cuff scar line is anterior to the vaginal apex. These points are really important and relevant. In post-hysterectomy cases, residual uterosacral ligaments, they are attached to lateral aspect of the cuff scar line. Means the top is still redundant. Now, how we evaluate? The way we are evaluating uterus with opposing lines of endometrial lines like this echogenic line, and if you follow this way, this is descending. This line is descending in the vagina. So this way, this is endometrial lining, and these are the opposing linings of anterior and posterior walls of vagina. This is anterior wall, this hypoid wall, and this is posterior wall. This is subtotal hysterectomy. This is cervical stump, and if we appreciate, because we are not focused to, we are not looking at, therefore we are missing all this. So if we appreciate here, this is the cervix opposing endocervical line. And if you look at here, this line goes towards the vagina. This echogenic line is due to opposing walls of vagina. This is how we evaluate normal anatomy. What we are looking at, this is internal urethral sphincter or meatus. This is urethra. This is vaginal line from here to here, this echogenic line. And if we focus, this is the rectum. Look at here. Posterior to the vagina, this is the rectum. And this area entirely is the perineum. But we need some manipulations. Means if we have to focus to the fundus of the bladder and looking toward the pelvis, inside pelvis. So that is again normal anatomy, different case. Just I am trying to orient everyone to get acquainted with all this and start evaluating this. So can we appreciate here? This is opposing anterior wall vagina, posterior wall. This is opposing echogenic line. This is the rectum. This is urethra. How I get it and how everyone can get it. So we take a mid-sagittal line across the uterus, then we manipulate, we look towards the pelvis, and then we get all this. So this is how I am getting it, everyone can get it. So this is the same way. Now something relations of vagina and urethra. Urethra is closely bound to the lower part of vagina, anterior wall of vagina. So look at this relationship. This is urethra and this is vaginal line. I have zoomed this image right now. We appreciate here rectum too, because by this mode we can predict pelvic organ prolapse. Therefore, we are looking at the rectum as well. So this is, I hope I am clear at this point. Now, female urethra is around 4 centimeter or 1.5 inches. Average total vaginal length is roughly 10 centimeter or around 4 inches. So now we correlate the length of average length of urethra with the length of vagina. If there will be pelvic organ prolapse, the uterus will distend and there will be an apparent shortening of the length of vagina. What we will be looking at in further some cases. Along with this, evaluating at vagina urethra, we need to look at both the views, because if we are dealing with some vaginal malignancy, we will need to look out at whether the bladder is infiltrated or the views are infiltrated. We will see in some cases after some time. So now how we evaluate this? This is how we evaluate both the views at the same time. This is something, this is normal finding. They are air punctate foci within the vagina. They are making some shadowing and like that. So this is just normal. In empty bladder, the vagina may apparently appear shortened. Like in this case, what we see apparently urethra is just smaller than the vaginal length apparently, but it's not so. Retroflexed, anteverted or antiflexed retroverted, in whatever be the case, the anterior lip hides the upper part of the vagina, and then that we may apparently feel that it appears to be shortened. But if we focus at the opposing lines of vagina, this line here, we may appreciate that it's not shortened, or if it is apparent. This is abnormal anatomy. What we see here, this is the urethral length apparent, 39 mm, and this is the residual vaginal length apparently. They appear quite similar in length. What is happening here? Can we appreciate? Like in previous normal cases, we are not able to get that length of vagina, although bladder is adequately filled. This is shortening. This is pelvic organ prolapse. Or okay, so there is no data about this statistics. So this was a study on cadavers which revealed total vaginal length is 7.5 centimeter, and total posterior vaginal length is around 9.25 centimeter. Now evaluating what we see here.
Who is the bolt? Who is the bolt?
This is the wall, this is vaginal length, here is the urethra. And there is no mass, no collection, nothing. So it's a normal vaginal curve. Now, regarding some findings, MRK syndrome, how to evaluate, everyone is knowing this. But if we apply these points here, what we see, this is the length of urethra, this is the length of vagina present over here, there is nothing, uterus, etc. nothing, not present. MRK syndrome. At real time, we see like this. That way, we are able to confirm all this. This is top of vagina in this MRK syndrome. This is one recent case.
मोबाइल में जो नाक डक सोल
MRK, urethra, ovaries are present, but both views are same, both kidneys present, means there is no other anomaly present. OH vira, obstructed hemivagina with ipsilateral renal anomaly. So this is transabdominal image, 3D. This is left hemivagina, this is right hemivagina. We see here a hematocorpus. It's right-sided hematocorpus. Her right kidney was not present at real time. So this was unusual case, uncommon case rather, OH vira. About benign lesions in prehysterectomy Gardner's cyst, everyone is looking at. More people rely on TVS, but in TVS we are not able to get that global view which we are getting in this transabdominal approach. So this is, we see, this is the transverse image, this is eccentrically left-sided image, this Gardner duct cyst, and this is global view, uterus and here. Posterior Gardner duct cyst, we are able to view here. Another case, anterior Gardner duct cyst. Now, is it Gardner duct cyst? My question to house. I will hint. This is focus at the opposing vaginal lines, echogenic line. So here the fluid is, where is the fluid? Yes, so this is formational fluid collection. It's nothing unusual. Again, this is another case having formational fluid collection similarly. How we differentiate it from Gardner duct cyst? By looking at this echogenic line. Look here. Can we appreciate it? Yes or no? Yes. Okay, fluid collection at what? In post-hysterectomy. After hysterectomy, it could be blood, lymph, or serous fluid with necrotic disease. So these are cuff epithelial inclusion cysts. Wall hematoma after hysterectomy can develop along the vaginal wall, usually on day 3 to 5, and may have such variety of symptoms or may remain asymptomatic. Now, in post-hysterectomy cases, these are some walled unilocular masses. What we see here, there is one eccentrically placed cystic mass here. So this is unilocular, absent flow on color. Another case with some internal echoes here, but it's unilocular mass. Hysterectomy 5 years back. This is huge collection, cup epithelial inclusion cyst. The same case at real time, previous case. So at real time we see this is the collection, this is the. Okay, multilocular masses. Multilocular masses, cyst within cyst, no flow on color Doppler. At real time, this is the situation. Urethra, bladder, vagina, and from top of the wall, this is the mass. That way we get many unilocular or multilocular masses. They are all cup epithelial inclusion cysts. Now about wall prolapse. how do we evaluate all this? So this is the view from means is the speculum view. So this is what we see. This is posterior fornix. This is anterior fornix. Cervix here is protruding into the anterior fornix. This is after hysterectomy. This is the cuff scar line. Do we appreciate this top of vaginal apex has been drawn with a forceps because that area, that top of vaginal apex is redundant and that means prolapse. That way. So total now we are knowing that total posterior vaginal length is around 10 centimeters and distance from vaginal vault on traction to anterior perineum. Now, what is important is posterior vaginal vault descent. That descent determines whether the lady needs surgical intervention or means surgical support or not. So, if a posterior vaginal vault descent of 5 cm or more is the cutoff for repair for vaginal vault support. So, this was the case. What we see here, this is clearly vault prolapse. Nothing is seen here. Urethra is not nicely seen the way we were looking at. So because urethra has gone down, vagina along with its vault has gone down. Therefore, we are not able to view those echogenic lines as well as the urethra. So this was cystourethrosphere. Both views normal, both kidneys normal. So that is the graphics for evaluation of prolapse. So this is the case. What we see uretrocystourethrosil. So here ureters are also involved within this. Can you appreciate this? Urethra funneling and appears outside. This is the top. Approximately half length of vagina is out. It's not being seen. This is the top. This is the vaginal vault apex. They are down. Regarding the ureters, both the uretral orifices, it has been evaluated. We are not able to view both the uses on either side, so they also have gone down. So that includes that uretrocyst. Again, this is another case for vault prolapse. What is the position of bladder? Can we see this peaking or funneling? Now, are we able to view the entire length of vagina or vault? No. Top of vault is also not seen. That is somewhere here. So this was cystourethrosil. This is second degree of pelvic organ prolapse, second degree prolapse. How we are going to evaluate all this? We use Valsalva. If we examine at first and then we are looking at something, there is nothing unusual, then we ask her to do Valsalva and the uterus descends. That way we are able to predict this. Now look here, after Valsalva, what is the length of apparent length? It has reduced. At the start, it was like this. So this was second degree prolapse. Third degree prolapse means apparently uterus at the introitus. Apparently. So this was. Can we appreciate any echogenic line, any vaginal line? Possibly not. Possibly not. Here we see this peaking of urethra, means bladder deep bladder outlet. About malignant lesions, vaginal malignancy, primary cancers of vagina are rare, but whatever they are mostly squamous cell carcinoma and few are adenocarcinomas. Secondary carcinoma of vagina is more common than the primary and may appear from cervix, uterus, vulva, bladder, bowel, or other. This is simply FIGO staging, and this is a case having discharge as well as bleeding theory. What we see here, on the same theory, same principle, look at here. This is vaginal opposing echogenic line. Here we see a mass. Description we all know. This is another view of this mass. Here is color Doppler. Can we appreciate here this infiltration of the bladder wall? Here we can appreciate bridging vessels over here in this color Doppler image at this point. Both views normal. This is left, this is right. I put my on the left, so that is I am using it. So simply to appreciate this infiltration of bladder serosa is lost. Another case, this was important because this case came to us with hypogastric pain but no bleeding pain. And let's look at her evaluation. Bladder. Can we see intermittent bladder serosa is broken because of this infiltration of the lesion? Infiltration. Can we appreciate? No. And both the uses involved bilateral hydronephrosis in this case, or this infiltration. Another case, hysterectomy, long back, heavy bleeding theory. What we get? Bladder, infiltration. No, infiltration. Look at the surface of internal surface of bladder. Both views, look at the view junction. Can we appreciate this all along infiltration here? No. Here, all along infiltration, along the views, means both views is too infiltrated. This is the color Doppler. And same case at real time, just simply to appreciate in the clip, real time. I will keep quiet for a few minutes. Okay. Another case, no bleeding theory, only discharge theory. Look at the huge mass. Urethra, roughly vagina. This is midline because this was eccentrically placed mass. Eccentric left-sided vaginal wart mass infiltrating left view only, causing left hydronephrosis. This is color Doppler image. At real time. Can we appreciate this? Okay. Now, open to us, please be interactive. In this clip, history is 58-year menopausal with intermittent spotting and discharge period, 2018 case of mine. Valsalva has been done at the middle of clip. So look at the start, this is the position, and I asked her to do Valsalva. What is happening? At the start, some vaginal length is there. With Valsalva, the cervix has gone straight down, even lower than the urethra. Isn't it? Now clinically the cervix is at the introitus, 3rd degree prolapse. Another another case on routine evaluation. This case was not aware of whether she was having something. Now there is an endocavity mass, but other than that, when I asked her to do Valsalva, that distance. Thereafter, we follow the case and then we do for her vaginal ward, we deal with prolapse. That is another thing. But how do we pick up these cases? So for that, this presentation was here. This case was having clinically mass birth.
Excuse me, Dr. Singh. Time is up.
Thank you, sir. So, in summary, vaginal wart can be evaluated in a majority of cases by transabdominal transvesical approach only. It may act as an adjunct to transvaginal sonography. Transabdominal procedure may be more acceptable and well tolerated by female patients undergoing sonography by a male sonography. POP and vaginal wart prolapse may be suspected and can be documented in most cases by this approach. And following the echogenic line formed by the apposition of vaginal walls and recognizing the internal urethral meatus with adequate or partially filled, not overfilled bladder is of paramount importance. Thank you. This case was published approximately 1,000.